All right. Okay. Good morning, ladies and gentlemen. Thank you for my first trip to Athens. Sadly, I have to go home tonight, but I have to work tomorrow morning. This is me, Dr. William Notcutt. I work at the James Paget Hospital, in a small hospital in the UK. I'm also the chairman of the International Association for Cannabinoid Medicines. My background is that I'm a specialist in pain, in managing pain. I used to be an anaesthetist until 2 years ago, and then just focused on working on pain. That's my hospital. It isn't very nice architecture, not like the architecture around here. I'm also a senior lecturer at the University of East Anglia in Norwich. I started work using cannabinoids in 1993. I've given evidence to government committees in the UK. My team were the first team to clinically study the medicine Sativex, which is an extract of cannabis, in 2000. And I've been treating patients with cannabinoids since 1993 in clinical trials and in ongoing and doing research. But I have to make the statement, look, I'm a full-time in the National Health Service in England. I'm not an employee of any pharmaceutical company. I have no shares in any company. I do receive fees for consultancy and some other work. I've been involved in about 20 clinical trials, mostly of Sativex, and I've been the chief investigator on some. And my research team has been supported by more than one pharmaceutical company. So I have done work, but basically I am independent. My plan is to talk, these are the things I want to talk about in the next few minutes: what medicines are around, what's happening a little bit in Europe, the therapeutic benefits, the benefits for patients, the diseases that we are trying to treat, how we give the cannabis, side effects, long-term use, and a little bit about the IACM. There is a lot of history going back to 1964 when McCollum in Israel discovered THC. And since then, there's been a lot of exciting research, as was mentioned earlier, discovering a receptor, the CB1 receptor, and then the discover that within our brains we have cannabis-like chemicals which are working and part of our normal physiology. Another person who's done a huge amount of work is Professor Pertwee in Aberdeen in the UK. Other receptors have been found, the CB2 receptor and other antagonists, to allow what has been the last 40 to 50 years a huge amount of basic research, laboratory research, almost all on rats and cells, small animals, and very little on human beings. So, why is this so? One of the first problems has been having a source of cannabis. Now we have to deal with right away what is the problem with this. Well, there are many problems with the cannabis on the street. The source may vary, particularly if you have a chronic illness. The strength may vary, the composition varies. The delivery system is not suitable. No drug. I'm a doctor. I administer no drugs by inviting the patients to roll them in paper and light them and smoke them. And then there's the legality and the whole problem, the issue of the recreational use of cannabis and the medicinal use. They are two different things. And what I've worked on and we're going to talk about is the medicinal use. And this is not suitable for the normal medicinal use. I would never ever give morphine this way by smoking. And this is somebody smoking opium from which we get morphine. This is unacceptable, I'm afraid, in modern medicine nowadays. And the problem we're doing is we're going to see what material is in this cigarette, what is lost when you smoke it, the products of combustion when you inhale it into your lungs, it can damage your lungs, how much you take in and what you breathe out. And this makes it impossible to do realistic modern clinical research with this technology. And I'm afraid we must do the research on it if we're going to be using it as a medicine. Another problem with inhalation, which will come to the later speaker will talk about probably, but is when we're treating patients is this problem. This is a graph of the plasma levels of THC. And this is THC when it is vaporized into the body, whether it is smoked into the body or a vaporizer. You can get very high levels of THC in the plasma. And this is what happens, this is the problem for patients, is they finish up getting very sleepy or euphoric, and whereas they don't want to be in that state. They want to be able to do things, to be active. If you look at the plasma levels when you take the THC by mouth or spray it into the mouth or swallow it, you can see the difference here, the pink line along the bottom there. That is the big difference between smoking or inhalation, which is much harder to control the effects than it is to take them by mouth by other ways. So what are the common routes that medicines are, the cannabinoid medicines are taken by? Well, orally, into the mouth, swallowed, by inhalation into the lungs, and you're going to hear about inhalation in a minute from the next speaker, and also spraying it onto the inside of the mouth. Now those are the three ways we use cannabinoids around the world at the moment as a medicinal, as medicines. There are, if you think about it, about 12 other ways you can give cannabis into the body, but I'll leave it with you to think about that one and how you do it. Vaporizers are being developed so that you can vaporize in a very controlled, regulated, and much better way than actually just smoking and inhaling into the lungs. And my colleague is going to talk about that in a minute. There are oral ways you can make it, cannabis into a tea. Doesn't taste very nice. Chocolate tastes much better. Cakes taste better. But there is a problem with taking by mouth, is that it's rather slow into the body, and it is difficult to control the dose that you're taking. For a patient, it is difficult to get the exact dose right. This is, I don't know whether this will work. Is this going to work for me? No, it isn't going to work for me. I'm sorry, that's supposed to be able to show you how Sativex is sprayed into the mouth. Sativex, by being sprayed into the mouth, is absorbed under the tongue or inside the mouth, is absorbed into the body and has a much better, much more reliable absorption into the body. So it is much more easy to control the dose. Patients have big problems in controlling the dose that they want to get exactly right, to do what they need to control their symptoms and not too much. Okay, so that's the sort of thing we want from a medicine. But if we want this as a medicine, we have to have quality, so we have to have exact constituents. We need a non-smoking method. I'll tell you, the health services, the regulators, the governments will not accept smoking as a way of delivering a medicine. It needs to have no contaminants in, pesticides, chemicals, fungi. It needs to be stable when it is stored. It needs to be safe as well. And as a doctor, as doctors researching cannabis, we have to show that what are the long-term effects, both the acute effects and the long-term effects. We have to show that there is concern that there might be psychosis. We have to show that that is not the case, that dependency is not a problem. and that these medicines are not going to be misused or diverted elsewhere. But then more importantly, we have to, as a doctor researching any medicine, I have to show that this is effective by clinical research. That it is effective for this purpose, for that purpose. And then in clinical practice, we have to show it is effective when it's being used in a clinic, in an everyday clinic, treating patients. With our delivery systems, we need a way that is reasonably precise in titration, so the patient can get the dose exactly right. That it is reasonably quick to have its effect, not perhaps 2 hours, but maybe 30 minutes or 10 minutes, depending on the system used. That it is predictably absorbed. It will always be absorbed in the same way into the mouth or into the lungs. And that if we can, avoid it going through the liver. One of the problems with drugs that go by mouth is they go in by mouth, they go down into the gut, and then they have to go through the liver. The liver takes out a lot of cannabis. It also takes out, for example, morphine. 2/3 of the morphine that you take by mouth is destroyed by the liver. But what we also have to do, we have to think of the politicians, we have to think of the government, the health services, that this should be safe and secure and convenient and approved by all our authorities. There are a lot of authorities out there that we have to make this, get this approved by. So, what medicinal cannabinoids are out there? First one is herbal cannabis, Bedrocan, which my colleague is going to talk about in a minute. There is Marinol from the USA, which is made in the USA, which is synthetic THC. Why they make it in the chemical industry and don't just grow it is beyond me. Then there is Nabilone, which is a synthetic variation on THC. Both these drugs were developed mainly for the treatment of nausea and vomiting associated with chemotherapy in cancer. Marinol was also made to treat, to improve the appetite of patients going with HIV and with cancer. And the final one, which came in about 12 years ago, is Sativex, which is an extract of the cannabis plant, grown in very controlled conditions. The Sativex that we are studying now, the extract we are studying now, is the same extract exactly chemically to that which we started studying 12 years ago. It's sprayed into the mouth, and that's the one we've done a lot of there's been a lot of research on it. I tried to find out in Europe what is the situation across Europe, and so if we look, Bedrocan, certainly in the Netherlands, I'm not sure in Brussels, but Tjalling will tell us a bit more about that in a moment. Dronabinol in at least 2 countries. I think Nabilone seems to be only in the UK. Sativex is licensed in those countries. The problem is that although it looks as if many countries have got cannabinoids licensed as drugs, they are not being used very widely. They've not yet come into accepted medical practice. Yes, there are a lot of good doctors like myself who want to go and prescribe, who want to treat patients with them. But most doctors are unsure, they're not certain about it, or they can't get them, or the regulatory authorities make it very difficult for them to be used. Just to show you what the regulatory authorities did to us in the UK, in in 2000, Nabilone was a Schedule 4 drug, as was Sativex, which is the same classification as diazepam, Valium. In 2010, they decided to change it, both of them, to Schedule 2, and make them like morphine. This changes how you prescribe the drug, changes the regulations under which we store the drug, we give it out, and many other problems as well. There were no reasons given why that was the case, but the government decided to do it. And then this year, what did they do? They decided that Sativex will be Schedule 4 again, like diazepam, but Nabilone will stay Schedule 2. No reasons why. And this is the sort of problems one comes up against with the regulators. Okay, move on. Endogenous cannabinoids. We've already, the first speaker just talked a little bit about endogenous cannabinoids. And this is one way to look at cannabinoids. It's the if you like, the medical way of looking at them. But this is the other way of what cannabinoids do. They relax muscles. They reduce the tone in the muscles. They damp down pain. They reduce pain. They help you forget. Pain is a great stimulator of memory. Not only physical pain, but psychological pain stimulates memory. Cannabinoids help you release those memories. There's protection of tissues. Cannabidiol, we know, protects tissues, particularly nerve tissue, from damage. They're part of sleep mechanism, of eating mechanisms. So they stimulate eating. And they're part of natural sleep mechanisms. A very, very important use of cannabinoids, a benefit of them, benefit of cannabinoids is improvements in sleep. Almost universal in our clinical trials. Patients have said, I sleep so much better now. But let's look at muscle tone. A lot of the research into cannabinoids has been on this condition, multiple sclerosis. And one of the real problem things people have is the spasms that they get with their arms or legs, the stiffness, unable to move about. And these can be extremely painful, or kicking out, suddenly shooting out, the cramp that one can get. We've all experienced cramp at some time. Imagine having that regularly, many times a night or during the daytime. So one of the advantages have been, we found that about 50% of patients who have failed with all other treatment for their spasticity, which is the muscle spasms, will actually get improvement with Sativex, which is, as I said, a cannabis extract. There's a whole lot of research now on this, good quality research, and these are just a few of the fairly more high-profile studies which have led to the regulatory authorities in the UK and into Europe accepting Sativex as an example of a cannabis medicine into clinical practice. The problem is that it still is not being used widely in clinical practice. The evidence for the effectiveness of Sativex as cannabis extract for spasticity in MS is better than the evidence for any other drug for treating this condition. Now you would think from there we should all be saying, right, let's use cannabis medicines for treating the spasticity. No, it hasn't happened yet. But one of the other groups we must think of, the benefits, is not just on the patient themselves, and that was spasticity and multiple sclerosis, but there were other benefits. One of the problems that patients have is they can have spasms at night and keeps them awake, wakes them up many times. They may have to go to the toilet to empty their bladder many times a night. They may be very restless at night. And that, of course, means that their partner, their wife, their husband, has to get up to help them or gets their sleep disturbed. And one of the things that we found was that in using cannabis-based medicines, Sativex, we found that not only did the patients sleep better, but their carers slept better. 70% of carers were getting a better night's sleep. That means they're able to their wife, husband, that much better. So, there are two people here. It's not just the patients, it's also the carers. But there are other potential targets. There's been some research, quite a lot of research now, into the treatment of various different pain problems, and here are some examples of areas that's still to be looked at: migraine, fibromyalgia. There are studies going on in terminal care or palliative care in people who are dying. There are, and in cancer studies, there's been work on rheumatoid arthritis in the treatment of not only the pain, but also the disease itself. There are other uses down here as anti-sickness. Some people suggest in epilepsy, there's work going on for treating psychosis, and also good evidence of anti-tumor effects, anti-cancer effects of these particular drugs. So there is a huge amount of work to be done. But one of the problems, of course, that people think about whenever you talk to people who don't know about this subject, unlike, of course, all of you, is the first thing they think about is side effects. What happens, because they imagine that anyone taking cannabis is going to be stoned. Well, that's the English word for it. I may have a different word for it in Greece, but and so what are the side effects we've seen with patients using cannabis extract as a medicine? So the common side effects, yes, they can sometimes feel drowsy, lightheaded, a little dizzy, but then this is the same, no different probably to most of the other drugs they have been using. In MS they use baclofen, tizanidine, gabapentin, all cause those symptoms. So many of the drugs that we already use produce these symptoms, and much worse than cannabis. And if they do take too much, overdose a little, then it passes off in 2 to 3 hours, and then they know to take a little less. So it is easy to find the right balance of the right amount to use. The less common side effects of panic, anxiety, euphoria, almost never seen. If somebody takes too much of a cannabis medicine, yes, they have that possibility. Other side effects, psychosis has not been seen directly used in the clinical trials in the use of cannabis extract. Addiction, dependency, that has not been seen either. When a patient has been using a cannabis medicine to control their symptoms, if they come off the medicine, then usually what happens is their symptoms all come back again. So having been well controlled, they stop the medicine, they suddenly lose all control of their symptoms again. Does memory go? Memory doesn't seem to be a problem. Increased appetite, I don't think I've ever seen a patient who's come and said, oh, I'm fine, but now I'm eating, I don't know, 3 Big Macs a day, and having a problem with putting on weight. Do they get excessive, having been the muscles very tight, do they suddenly go like that? No, it can happen, but that's again an issue around getting the dose exactly right for the patient. But also what we must remember here when we're talking about side effects is a disease like multiple sclerosis and many of the other diseases there are associated with suicide, with euthanasia, and with a shorter lifespan. So if people are getting some side effects, one must balance it against the worst aspects of the disease itself. In the long-term use then of Sativex, we've not seen any medical problems emerge. No liver problems, kidney problems, heart problems, unlike many other drugs. And withdrawal, well, as I said, withdrawal of the drug, if you stop the drug suddenly, then the symptoms can come back. If patients want to come off the drug, off cannabis extract, then I always suggest that they step it down slowly over a week or 2 so that they don't suddenly get all their symptoms coming back. But But we have, you know, that suggestion, but this is actual data here from the use of Sativex, a cannabis extract, using it on long term. These are the doses that they're using over a period of 1.5 years. There's almost no change in the dose. Unlike with morphine, unlike with many other drugs where one sees a steadily increasing dose, here there is no change in the dose. I've seen this with, rarely have I ever seen anyone increasing the dose, and if they do increase the dose, it's because their symptoms have got worse. Okay, just a few words on the IACM. The IACM is an organization of cannabis medicines. It's really there trying to promote the clinical aspects of the use of cannabinoids and to look at the clinical research that's going on, not so much the animal and the basic laboratory research. But what one has to remember is the IACM work is not a political organization. And these are some of the problems that one comes up against with doing research. These are some of the huge problems of doing clinical research. And I've been involved with it for 15 years. I'm the lead for research in our hospital. I spend my time with reading documents and reading about regulations, and trying to get research through is very, very difficult. But there are also individual national laws. Every country is different in how they're going to approach these sort of issues. The politicians, no politician likes to talk about cannabis or any other drugs of dependency. They don't want to know about it. It loses votes. And then the media, who love to make a big show about something. One day they'll be supporting cannabis, another day the media will be telling you that cannabis is driving all the children mad. And then there are problems of driving regulations, which are different from country to country. So this is a very complex area. Outside, you know, it's difficult enough to do the medical research, but once you get out into these sort of areas, again, it is hugely complex. So some final thoughts then. Someone, a Judge Francis Young in 1988, said that marijuana, cannabis, is one of the safest drugs or safest substances known to man. Safer than many foods and medicines, I put that in, we currently consume. It is very, very safe. Anti-inflammatory drugs cause about 2,000 deaths a year in the UK. 2,000 deaths a year from a medicine that you're using to control pain. 1 in 4 homes in the UK has a person with chronic pain. 1 in 4 people over the age of 65 suffers with chronic pain. I am over the age of 65. Believe it or not, you probably think I'm much younger, but this is a huge problem, okay? And we don't have the medicines for treating pain around. Interestingly, you might want to know, there's only been one radically new medicine for treating pain in the last 30 years, apart from cannabis. Okay? So the biggest problems are prejudice, the politicians and the media, and the cost. To bring new drugs to the market, to be able to use them, is a huge cost. And to prove that they are safe, to prove that they are helpful for patients, costs a huge amount. The estimate is it can take 10 years of research and cost maybe €500 million, pounds. You haven't got €500 million euros to spend in Greece, and we haven't got £500 million in the UK. Easy to find, that we can find easily. So big cost. But the research has to be done. And if you say that, oh, we don't need research, I'm sorry, that is the result of poor research, which is thalidomide. And a lot of the regulations on drugs, on getting drugs through to be using in patients, are because of the effect of thalidomide about 40 years ago. So that's why we have to do the research, the medical research, and it slows things up, it is frustrating, but that has to be done. So, thank you. There is a long journey still to be had in finding out what the benefits are of cannabis, cannabis extracts, whatever we're using. There's a lot of work to be done. Morphine has been researched, pure morphine has been researched for 200 years and is still being researched to this day. Now cannabis has only just started really the clinical research, but there is a long way to go. Here is one of my colleagues. That is where down Sativex is grown under very controlled conditions. Thank you very much for listening.